morning, everybody. Today we're having Agnes Magwete here, and she's going to be presenting on diabetic hepatopathy. So first of all, Dr. Agnes is an experienced chemical pathologist with over 26 years of experience in the medical field. She is currently based at Ampath Private Laboratory, where she serves as a consultant pathologist in the Gauteng North Region and the National Reference Laboratory. Dr. Magwete's role involved overseeing standardization of chemical pathology, reporting and introducing new diagnostic tests, and ensuring the quality and control of the laboratory processes is up to standards. Her previous experience includes leadership positions at NHLS, at Charlotte Maxeke Academic Hospital, and Chris Baragwanath Hospital, where she was responsible for laboratory management, quality assurance, and training medical professionals. Dr. Magwete has also worked as medical officer in internal medicine and pediatrics. She also holds an MBCHB and an MMed in chemical pathology from Medunsa. And she has also completed management programs at Wits Business School and INISA. So that's not impressive. Her research has been published in notable medical journals, with her recent work focusing on lipid analysis and iron studies. So thank you so much, Agnes. We're looking forward to your great presentation.
Thank you, Michelle. Yeah, as they have alluded, our topic today is diabetic hepatopathy. This is the disorders of the liver associated with diabetes mellitus. So normally when we talk about liver disorders in diabetes mellitus, we normally think about fatty liver disease, which is commonly associated with type 2 diabetes, obesity, and it can also form part of the metabolic syndrome. But today, I am particularly going to talk about glycogenic hepatopathy. This is a disorder that is associated with uncontrolled diabetes mellitus, particularly type 1 diabetes mellitus. It's said to be a very rare and underdiagnosed condition, and it's potentially reversible. What inspired me to talk about this case today is that we had a diagnosis that was made recently. I think it was the past month, and it was the first time for me, and it was the first time also for the physician who consulted, because now he wanted to know how further to investigate the patient. So we all, both of us, had to go and read about this before. So I thought maybe I should just bring it to your attention and just bring awareness to this condition. So I'm going to illustrate this condition with the case presentation. I'm presenting here an 18-year-old male with uncontrolled type 1 diabetes and recurrent diabetic ketoacidosis, or DKA. This patient presented to the emergency department complaining of abdominal pain and abdominal distension for weeks, worsening over the last few days, and also had nausea, early satiety, and bloating. He reported normal growth and pubertal development. He has had multiple hospitalizations for DKA due to poor compliance with insulin therapy. So physically, this chap looked tiny with no acanthosis nigricans. No syndromic features were noted. That is, the doctor looked for dysmorphic features. He had dry mouth, dry mucous membranes. He was tachycardic and with a normal blood pressure, and the patient was also afebrile. And then of note was that this patient had a non-tender but massive hepatomegaly. So the initial lab evaluation, as you can see, the glucose was 27.8 with metabolic acidosis, and confirmed by that arterial blood of with the pH of 7.25. So What was evident from these blood results was that it was consistent with DKA, or diabetic ketoacidosis. And also, there was also evidence that this patient was poorly controlled with that HbA1c of 12%. And also of note was the significantly raised liver transaminases with an AST of 1,162 and an ALT of 598. So even with these significantly raised liver enzymes, there were no signs of acute liver failure. And bilirubin, albumin, and coagulation profile were normal. So DKA was managed in the ICU with IV regular insulin infusion, and patient was subsequently transferred to a medical ward on a basal bolus, a subcutaneous insulin regime. So the follow-up lab test while the patient was in the medical ward, we see that even after the intensive, management of that DKA, the liver enzymes continued to rise. They rise and they peaked day 3 after admission. And we also see that lactate, which initially was 2.4, also peaked day 2 after the patient was intensively treated for DKA, it peaked to 8. And then what we also noticed here, or we can notice here, is that as the glycemic control improves, and then we see that glucose now is below 11, we also saw now the downward trend of your AST and ALT, and also your lactate also, reduced. Of note is that the albumin, the bilirubin, and the coagulation profile remained normal throughout the stay in hospital. So the abdominal sonar was done in this patient, which revealed an enlarged liver with moderate echogenicity, which was suggestive of steatosis or fatty liver. And in view of the progressive elevation of the transaminases in this patient, further lab evaluation was then done for hepatomegaly and raised liver enzymes, because the rise and the levels of those transaminases didn't fit in with what the abdominal sonar diagnosed in this patient, the steatosis of fatty liver. Because in these patients, we normally see low level increase of liver enzymes that is persistent. But in this case, we saw that there was significantly raised liver enzymes that continues to rise even after, the DKA was intensively managed. So what the doctor then sought to do was to exclude other common causes of raised liver enzymes and hepatomegaly. So we started by doing ruling out autoimmune hepatitis, because we know the association between type 1 diabetes and autoimmune diseases. So he did the serological test to rule out the autoimmune hepatitis, which was negative. She also sought to rule out any active, acute or chronic viral hepatitis, which were also negative. And he also continued and went and did ask further questions about drugs from this patient. And the patient denied having taken any other drugs except the drugs that he's using to manage the diabetes mellitus. And also he denied taking alcohol. So toxicity screen was done, which was negative. So seeing that there was still no diagnosis, the doctor then decided to do an ultrasound-guided liver biopsy, which then showed a swollen hepatocytes with intracytoplasmic glycogen accumulation, which was then consistent with the diagnosis of glycogenic hepatopathy. And that's when the doctor consulted, now wanting to know how further to investigate, because now he wanted to also exclude the glycogen storage diseases. So we wanted to know which test to do now to exclude the glycogen storage diseases, which is that, effectively to exclude all those diseases that can contribute to hepatomegaly and glycogen deposit. The doctor had to do a full screen of the gene mutation analysis for all those conditions. And unfortunately, we were not able to offer that at Empath, and then we sought assistance from overseas. So after we went and read, then we knew that this condition is self-limiting, and what the doctor then had to do was to continue managing and optimizing the glycemic control in this patient. So as glycemic control improved, the liver enzymes started to decrease, as we say, from day 4 on those results, and the abdominal symptoms mostly resolved. Then this patient was discharged home with closed outpatient follow-up. So what is glycogenic hepatopathy? So it's a liver disorder that occurs primarily in individuals with poorly controlled diabetes mellitus, particularly type 1 diabetes mellitus, but it was also reported in patients with type 2 diabetes mellitus receiving insulin therapy. It was characterized by excessive accumulation of glycogen in the liver, which then leads to hepatomegaly and raised liver transaminases, your ALT and AST, as we saw in this patient. So it was first described in 1930 by the chap called Pierre Mauriac, and it was incorporated in the syndrome called Mauriac syndrome. This syndrome described a rare complication of poorly controlled type 1 diabetes in children. So this syndrome was characterized by an overloading of hepatocytes with glycogen, and patients presented with hepatomegaly and abnormal liver function tests. And this was associated with growth failure and delayed puberty and Cushingoid features in this patient. So of note is that this complication was noted shortly after the introduction of insulin in 2022. So later it was then recognized that adolescents and adults with uncontrolled diabetes mellitus on insulin therapy may also present with hepatomegaly and raised liver enzymes, but without the other syndromic features that were described in this syndrome. And subsequently, I think it was in 2006, the term glycogenic hepatopathy became a more unique pathologic entity to describe this condition. So the true incidence and the prevalence of this condition, glycogenic hepatopathy, are unknown. And of note is that approximately about 98% of published cases were reported in patients with type 1 diabetes mellitus. So the hallmark of glycogenic hepatopathy is thought to be the severe fluctuation in levels of glucose that we see in these patients who are uncontrolled, and the subsequent administration of insulin to control the hyperglycemia. So in these patients, persistent hyperglycemia and the high dose of insulin that is used to control this hyperglycemia are the driving factors of intrahepatic glycogen deposit. So during hyperglycemia in these patients, high levels of glucose enters the hepatocytes, but this is via facilitated diffusion through the glucose transporter 2 protein. And this action is independent of insulin. And then once this glucose is in the hepatocytes, it's then rapidly converted irreversibly to glucose 6-phosphate. So it becomes trapped in the liver in the form of glucose 6 phosphate. And then subsequent treatment with high doses of insulin then activates the enzyme glycogen synthase, which is a key enzyme in the process of glycogenesis or formation of glycogen. So once activated by insulin, the glucose 6 phosphate then is converted to glycogen. And during this process, there is inhibition of glycogenolysis, which is glycogen breakdown, and gluconeogenesis is also inhibited. Gluconeogenesis is the generation of glucose from non-carbohydrate substrates like lactate, for instance. So this deposit then will cause the deposit of glycogen in the liver, then will cause overload of glycogen, which ultimately will lead to hepatomegaly. And then we will also see raised serum transaminases, and this is due to the leakage of this enzyme from the hepatocytes. So the reduction of gluconeogenesis in these patients may also result in lactate accumulation, because normally, like I said, I mean, lactate can also be used to generate fuel for the body through pyruvate and then back to glucose. But in these cases, gluconeogenesis is inhibited. And this is what we saw in this in our patient. So when do we suspect that the patient has glycogenic hepatopathy? So it should be suspected in patients with uncontrolled type 1 diabetes mellitus, who also present with exaggerated HbA1c levels, like we saw in our patient with the HbA1c level of 12%. And these patients presenting with hepatomegaly and raised liver enzymes. And it will also be a bonus if you can also observe the reversibility of the symptoms with improved glucose control. So in those cases, then you should suspect that this patient has got glycogenic hepatopathy. And then the biochemical features that we expect in this patient, or that have been described in this patient, is that they present predominantly with elevation of AST and ALT, which is the hepatic function, the hepatic liver cell damage pattern. All right. And some of them also may present with cholestatic pattern, where also there's, in addition of the to the AST and ALT, there will be increased in your ALP and your gamma GT. So this patient also may present with marked elevation of ALT and AST, as we see in our patient, in the ranges of about 100-fold the normal, where and then this may mimic, I mean, acute hepatitis. And this is also reported in patients with DKA. Okay, and then the liver synthetic function in this patient is usually preserved. That is, your albumin and your coagulation profile are usually normal in this patient. And also bilirubin is usually normal in this patient. So meaning that you only have this raised liver enzymes, but the liver function is preserved itself. So these patients may also have raised lactate with or without DKA. Because we said also that the raised lactate may be as a result of the inhibited gluconeogenesis. So imaging studies in this condition have shown that both abdominal scan and the abdominal scan and the CT scan and abdominal ultrasound cannot with certainty make a diagnosis of glycogenic hepatopathy. But dual echo MRI was found recently to be able to just provide a clue. So it doesn't give a diagnosis per se, but it can just provide a clue that this patient may be having a glycogenic hepatopathy. But of note is that liver biopsy is the gold standard for the diagnosis of this disease. And there are some characteristic findings on histopathology that indicate that that the patient has got glycogenic hepatopathy, like marked glycogen deposit with pale swollen hepatocytes that we're seeing in our patient. And there is mild fatty changes, minimal or no inflammation, minimal or no spotty lobar necrosis, and also the architecture is intact with no significant fibrosis. So those are some of the characteristics that are expected on histopathology, on histology. So what is important is that we need to exclude this or differentiate this condition from the commonly known fatty liver disease or the non-alcoholic fatty liver disease, because these patients can easily be misdiagnosed as having a fatty liver disease, because you saw on ultrasound, the ultrasound was suggestive of steatosis or fatty liver disease, but in fact, with the biopsy diagnosis, it was confirmed that it was not a fatty liver, it was a glycogenic hepatopathy. So both of them, the glycogenic hepatopathy and the fatty liver, they present with hepatomegaly and raised liver transaminases. And of note is that the ultrasound cannot distinguish between the two. And the pathologic features of fatty liver, such as fibrosis, steatosis, and portal inflammation, are not seen in patients with glycogenic hepatopathy. And unlike the fatty liver, glycogenic hepatopathy is a benign condition, not associated with progression to fibrosis, to cirrhosis, and eventually to hepatocellular carcinoma. So it's just benign self-limiting condition. And treatment also is different. So that is why it's imperative to differentiate between the two, because for glycogenic hepatopathy, what you just need to do is to optimize your glycemic control that will reverse the condition. And for fatty liver disease, you have to optimize treatment for the risk factors, and also a lifestyle modification is indicated. So it's very imperative to differentiate between the two and guard against misdiagnosing glycogenic hepatopathy as a fatty liver disease. So the differential diagnosis, except for the fatty liver diseases, like we said, I mean, this doctor wanted to know now how to exclude now glycogen storage diseases. Glycogen storage diseases are inherited conditions where there is a mutation in the genes that code for the enzymes that are responsible for the breakdown of glycogen during fasting, because you know that we need glucose as a form of fuel throughout. So during fasting, then glycogen, which is a stored form of glucose, is then broken down to release glucose into the system. So in these patients with glycogen storage diseases, they have the mutations in those enzymes, on those genes that code for these enzymes. And as a result, they are unable to break down successfully glycogen to produce glucose during fasting. And some of these patients may present even in childhood with hypoglycemia. So, I mean, history will be important here before you even go and do the expensive diagnostic procedures to rule out this condition. And like I said, we didn't have a full panel at Ampath, so this patient, the doctor was then referred to go and do it overseas, which was a bit expensive also. All right. So the other conditions that you need to exclude in this patient is autoimmune hepatitis, like we did in this patient. The viral hepatitis, those are the common causes of raised liver enzymes. You should also exclude them, and also exclude the drug-induced hepatitis. So history also is very important here, and you can even also go and do your toxic drug screen to exclude drug-induced hepatitis. And the other condition that you can exclude is hemochromatosis or this bronze diabetes, because this patient also may present with what looks like type 1 diabetes mellitus. And also, but here we know that the deposition is not only on the liver, but also the other organs will have iron deposit. So they may present not only with hepatomegaly, but with hepatosplenomegaly. And they may also present, because history is also important here, that they may also have joint pains, and other things that would, suggest that the patient had iron overload. So with treatment, what I've have been noticed is that this condition, glycogenic hepatopathy, it's reversible with good diabetic control. As we have seen in our patient, when the glucose levels went below 11, then we saw a decline or a downward trend of our liver enzymes, and also the lactate that was also going down. But unfortunately, it can recur and relapse with uncontrolled glycemic control. So in conclusion, glycogenic hepatopathy should be considered in patients who are poorly controlled with diabetes mellitus, especially type 1, who present with raised liver enzymes and hepatomegaly. It is very imperative to differentiate it from the most common fatty liver disease that is commonly associated with diabetes mellitus, because the treatment and prognosis differs. Because if you know that this patient has got, or if you have a suspicion that the patient has got a glycogenic hepatopathy, then you can give a trial of strict glucose control and see if the condition reverses. And yeah, that will help, because if you have knowledge of that condition, then the patient may not even go to this invasive liver biopsy thingy, because now you will control strictly the glucose levels, and then see the reversal of the diagnosis. And liver biopsy at the moment is the gold standard for the diagnosis. And what is important is that this condition is reversible with improved diabetic control. Thank you.
Wow. Thank you, Agnes. I think for me, you just raised the standard up a bit more. And also, you told us something that perhaps I think we always, we treat DKA, but little does that actually cross my mind, because we have not seen, and in medicine, you only treat what you know. And if you don't know it, you don't think about it, because it always doesn't exist. Okay, and I think that's where the problems comes in, because I think for those conditions, we do see a lot of patients with uncontrolled diabetic, and most of the time, obviously, we have a bias as a train, when we get trained as physicians. When you do AST-ALT ratio reversible, what's the first thing goes to your mind? Alcohol. You tend to ask the patient more than 100 times, do you drink alcohol? If you say no. Do you drink alcohol? The question goes on, but the truth that we should be looking beyond that. And I think for the students, it would be very nice if you guys can give me the first diagnosis of reverse AST-ALT ratio. What condition can give you that?
I can change hepatitis.
Okay, that's number one. Alcohol, great.
Alcohol.
Congested heart failure, any kind of liver fibrosis can give you that, which is quite very good. And I think there was quite highlight. And then the second thing, I think we have to change the refreshment of the topic, because not many people are going to understand it. Because the thing is just something rare. Maybe we need to be talking about ketoacidosis and what are the possible complications that could happen. Then we put it underneath. I think maybe that's what we must do, because nobody's going to watch it because they don't know what is it all about and they think it doesn't happen. But this is really something that I think all doctors, physicians need to understand. It's common out there. There are a lot of patients out there, and those patients probably being condemned as drugs or alcohol or something like that. But while it's really existing, because South Africa, we see quite a lot every year. We admit almost about recurrent chronic kind of acute complication of diabetic. For now, you are the king of diabetic.
No, it's something
Have you
that
seen
we
one?
have to. No, we'll have to look out for it. So, but is it mostly in type 1s? You get it in type
Yes.
2s as well, or not?
They say in type 2s who are on insulin.
On insulin.
Yeah.
Okay, because a lot of our type 2s are on
Insulin.
baseline insulin, Tresiba or Lantus, of one of those. And your lipid profile, is there any abnormality or any association with an abnormal lipid profile? Or
I think the lipid profile abnormalities will be the common lipid profile abnormalities that you see with diabetes mellitus. Your high triglycerides in these patients. So that will be the common, but it's not really associated with.
Yeah. Because I think the difficult one is going to be the type 2 diabetics, who's overweight, who is on insulin, who's got abnormal liver, but they're also drinking. This 18-year-old type 1 diabetic, don't expect it. So it's going to be more difficult to diagnose in the type 2s.
Because again, I mean, the fatty liver can coexist with this condition. So, and that is why in some cases it will be advisable or recommended to do liver biopsy to make a proper diagnosis, because you know that if it's a liver or fatty liver, then the prognosis is bad, because they can progress to fibrosis, to cirrhosis and hepatocellular carcinoma, and then you have to treat aggressively.
So I have two questions. Number one, have you read anywhere that when you say it's reversible, the condition is reversible, the symptom is reversible, that's how we're measuring it. But on liver biopsy, has the glycogen storage regressed? Because
that's why they say that after, everything regresses, because this condition depends on hyperglycemia with supraphysiologic insulin. So without those two,
it should regress.
it should
glycogen
regress.
storage.
It regresses totally.
Okay.
Yes.
And number two, is there, now you say it can recur,
Yes.
is there a degree of uncontrolled hyperglycemia that could correlate with this glycogen storage? Basically, is there a threshold?
There's no threshold.
There's
no threshold at the moment. That is something that they said they should be. It's a matter of research.
I think it's up to be recurring, because it can't be a single episode. HbA1c of 12, and it's an 18-year-old probably got a type 1 with childhood onset.
Yes.
And that means for a long time there's not really control. But maybe the insulin is going down now with the onset of insulin pump.
Yes.
Yeah.
Was this HbA1c increase?
Students, again, Agnes mentioned something special. One of the differential diagnoses is hemochromatosis. And Kalago did a discussion on hemochromatosis. Now the question that, Agnes, question to you. Now when you're having hepatitis, your ions will be very high. Okay? Because you will have liberation of iron in the blood because of destruction. Now the question that's, how do you make the diagnosis of hemochromatosis? Yes, Jay, your head is up.
No.
Did you guys watch the presentation? No. Okay, the question that you have to do genetic tests. You cannot assume, because your iron level will be very high. But I think probably Michelle can tell you, perhaps you might not need to, because you could actually, can you just get a secondary iron overload from the hemochromatosis just on the iron profile? Or you need to have more detailed tests?
So you look at your iron, usually in let's say anemia of inflammation, your ferritin can be high. So ferritin is acute phase reactant. So if you've got inflammation, infection, anything, ferritin can be raised. So you do not just want to look at your ferritin. A very, very important thing is if you see your iron level is low and your ferritin is high and your saturation is low, that's anemia of chronic inflammation. So if your saturation is below 20, it means there's a high iron storage, but it can't be used into the red blood cells. So that means there's inflammation. If you think about hemochromatosis, you see your ferritin will be high, usually above 500, and then you see your saturation will be more than 20. It's usually high. So look at your saturation level.
I think the saturation part is the most important aspect because we do see those what you call heterozygous mutation of hemochromatosis where iron actually can be low. So we do see those patients, okay? Or some of the patients with hemochromatosis could have just been gone for pleurectomy and most of the iron been removed. So I think the saturation is probably the most important aspect of it. So you always that again, there's no substitute for thinking. You have to think. If you don't think, nothing happens.
And
Okay.
the obvious things exclude iron supplementation and recurrent lab transfusion. So,
Yeah.
of course.
But also ask your patient, is it male or female? Because it matters when that happens. Males earlier, female at the age of 45.
Why?
It is great. Why?
Menstruation. That
So you have to do your history globally. Cornell, you want to say something? Yeah, but this is really, I think for me, that's the reason for this presentation, because you need to have these topics, things that really just give you a goosebump that you actually show you like, I don't think I know medicine. Because for me, the moment you know medicine, you just need to maybe go on pension. Okay. But you always, you never stop learning. You always, there's so much ongoing learning. And I think probably this platform is really for that reason, to make sure that we stay on top of our game and we learn from our colleagues. So everybody contributes somehow. Dr. Coley? Emmanuel, are you online? Have you seen one?
Online.
Have you seen one in Secunda since you only came in that?
To be frank, I haven't, but I guess I'll be on the watch out now.
Have you thought about it before?
No?
Have you thought about one before? Have you think that it exists, or are you just learning like me for the first time?
I haven't. I think most end up with the alcoholics or the non-alcoholic steatotic liver disease.
Okay, that's how we would be thinking. Thank you so much. If there's no further question,
No. I mean, you will go down the. Obviously, it won't be the first thing that comes to mind.
No.
You will think of first of hepatitis, all the hepatitis, the autoimmune things, the drugs, and then
Yes.
probably. Luckily, in our case, once you get stuck, we will ask the gastroenterologist.
Okay.
no, you see, I think it's just yeah. No, I think I learned something. I really thank you.
Look at this
I really
one.
appreciate it. But please always rephrase that. I think maybe the first question: are you suffering with recurrent DKA? What's the complication? Let's chat about that, because that would be the problem.
No.
No,
Because this is a liver condition.
No,
The patient did have a DKA uncontrolled.
but it's not from DKA.
Yeah, no, but we see a lot of DKAs, but we see poorly controlled diabetics, but you don't get that abnormal liver enzymes. So, and as you said, it must be more than 100. The AST.
So maybe then you're
So
phrased.
you get sometimes a bit of slight elevation, but it's not that high.
Yeah.
So in a DKA,
But maybe that's a time that we should actually be looking for. No, my point is that for physicians out there, maybe if you said diabetic after hepatopathy, they will not even understand it. But maybe it's better to say DKA with abnormal liver function, what to look for. Just to make sure to catch people when they now do it, then even the GPs, then because we have a lot of people that follow us online that actually watched last week. I think we have almost about 300 people where they watch the platform. So at least people can be able to associate it when they see DKA, because that's the most commonest thing. Then they could actually, like the way now, because we watch the presentation now, we understand DKA, and every DKA that come, we're going to be looking for it. Yeah.
no, especially with abnormal liver enzymes.
Yeah. So exactly. So I think we
think
just
that's
have to replace that. Okay.
Crooks.
Thank you. I think we're going to exit that one. Thank you. This is really nice, Agnes.